Good afternoon and welcome to another version of Ombudsman Corner. Today we're going to talk about consultant pharmacists in the facilities. We've all heard times where the facility says, oh, we're going to have a consultant in and look at the medications. Today we have Mr. Bill Vaughn. He's with Remedy Senior Care. After a 26-year career with Maryland State Survey Agency, the Office of Healthcare Quality, Mr. Vaughn was CMS Certified Healthcare Facility Surveyor in Maryland. He's also taught pharmacy and nursing students at the University of Sciences in Philadelphia and the University of Maryland School of Nursing and Towson University. He's on the CMS expert panel, which developed guidance to surveyors on pain management medication and end-of-life care. He's currently a contractor to CMS, developing training and changes to state operations manual related to quality assurance and performance improvement. So I feel like he's very well qualified to speak to us today about what a pharmacist review in a long-term care facility is. Mr. Vaughn, tell us a little bit of how you got into this field.
Sure, I'll be happy to. First of all, thank you for having me. Mike and I talked about doing this probably a month and a half ago. When we talked, I live in Maryland, so it was less than 0 degrees when we were talking, and I was incredibly anxious to come down here. When I landed in Jacksonville yesterday, it was actually warmer in Baltimore than it was down here, so you get what you pay for. But anyways, I've been a nurse for about 35 years. I spent the majority of that time working for the Maryland Survey Agency. So I was a surveyor from the late 80s till 2001. Then I was chief nurse of the office from 2001 to 2013, and I've been with Remedy Senior Care since. As a surveyor and chief nurse, I spent the majority of my time looking at, focusing on, and helping better medication management and long-term care. So it's really a sweet spot for me, and I'm just delighted to be able to talk to you all about medication management.
Well, this is one area that we're kind of lacking in our training in, so we certainly want to gather more knowledge so when we go into the facilities, we understand when they tell us they're having a review, we know what they're doing. So kind of explain to us, what's a day in the life of a pharmacist going into a facility?
Perfect, exactly. So that's kind of what I entitled this brief discussion. What's it like to be a consultant pharmacist? Why are they there? How often do they come in? Where do they document? Who do they interact with? So my goal when we're done with all this is you have a better understanding of this pretty important role in long-term care. So a couple things. When we say long-term care, we're talking about nursing homes on the federal side and assisted livings on the state side. So I think what's telling about the role of a consultant pharmacist is that it's been mandated in nursing homes for over 30-some years. So the government sees, I think, the risk and benefit of medications in long-term care as needing a lot of shepherding. And so consultant pharmacists are specialists in medication management. So they are in nursing homes at least once a month. And depending on my company Remedies in about 30 different states. So assisted livings have varying degrees of consultant pharmacist involvement. One of the things I want to leave you all with today is whether we're talking about a loved one in a nursing home, an assisted living, or quite frankly at home in the community, good pharmacy care is not dependent on where your body is. Good pharmacy care is good pharmacy care across the board. So the tenets I'm going to talk to you about today really apply to the continuum of care and not just the heavily regulated area of nursing homes or the lightly regulated, at least currently, area of assisted living. So a typical day for a consultant pharmacist includes a couple of things. They generally go to facilities and do the review of medications. That means they're not sitting at a desk somewhere. They're actually going to the facilities, looking at the medical record. And I'll get to certain things that I want to talk about. Geriatric principles. Let's talk about what drives them to look at certain things and not others. I want to just tell you a couple geriatric principles that I think as ombudsman you should know about medication management. And the first one might surprise you. So the geriatric principle of medication management is don't use drugs if you don't have to. Right? Use something other than a pill to affect whatever change you're trying to get at. Now, high blood pressure, you can do biofeedback, you can do lots of other things to lower your blood pressure. I think all of us have been involved in kind of the assault on antipsychotics in long-term care for these past 7 to 10 years, and it's to no one's surprise that the regs actually require nursing homes to use something other than a pill to treat dementia-related behaviors before we go to a medication. So you may be surprised to know that doctors and pharmacists and nurses think of ways not to use pills before we need to use them. The reason we're living longer, the reason we're doing better in life in general, is in part because of all the advances we've gained in medication. But medication has its place, and I think as a culture we're very quick to pull the trigger on medication. You should know that consultant pharmacists, I'll give you statistics that in our field, I work with 44 consultant pharmacists over about 30 states. For every one recommendation they make to the doctor to add a medication to a geriatric resident, they have 18 recommendations to decrease a drug or get rid of it altogether. So again, there's a bias to get away from drugs when you can. We think about other areas. What about drugs to help you sleep? Well, there's other ways to help you sleep too. I'm not sure that hot milk before bed is a terribly bad thing compared to taking a pill with side effects. A lot of our residents have trouble with maintaining weight or weight loss, so we have pills out there that, at least in theory, can help that. But I think many people would say, how about let's just really improve the food? Let's take the time to feed people. Let's bake bread and have the smell of bread throughout a facility to encourage appetite. So again, just a takeaway would be pills have their place, but they are not the end-all be-all. Another geriatric principle that our consultants go by is when we are going to start a pill, the phrase is start low and go slow. So, a 25-year-old could handle a certain dose of a drug that a 70-year-old can't handle. So we start with doses that are generally lower, and we don't increase them right away until we see how residents react. So sometimes you may get complaints from family members or even the residents themselves that the pill's not working. There is a strategy to using pills judiciously and not aggressively. Additionally, we're always looking for the lowest effective dose of a drug. We're looking to see what can we get away with and giving you to make you better, but trying to limit the side effects. The term gradual dose reduction speaks to that. I've been on this pill for, I'm making this up, hypertension for 10 years. How do I know that 10 milligrams less won't control my hypertension just as well? So this issue of gradual dose reduction, getting to the lowest possible dose, is important. And here's probably, if you don't remember anything I say today, and you may not, here's something I want you to remember from this discussion. In geriatrics, any change in a resident's condition, change in behavior, change in appetite, onset of coughing, onset of falls, bleeding, vomiting, any change in a geriatric resident's condition is presumed to be a medication side effect until proven otherwise. So docs and nurses and consultant pharmacists, when we have a change in condition, we first look at the medications and say, can any of those be causing this? Because it so frequently happens that medications are a cause of change, and we can actually do something about it. We can decrease the dose or eliminate the drug. So that's a huge geriatric principle that we live by, and it's good for you to know. So I think in terms of kind of something we always forget across the board is the involvement of the resident or the surrogate decision maker in everything we do in long-term care, but in medication management. So I'll talk to you a little bit on about what I call informed consent. How much are we involving the resident when we start them on a medication, continue them, or decrease the dose? And are we making sure they understand why they're getting the med, the risk and side effects, and alternatives to what we could be doing? So their place at the table with medication management is, quite frankly, pivotal. Person-centered care, more than a catchphrase. It's really how care should be delivered, and our consultants look at that consistently when they're evaluating the care the residents get.
Now, when you talk about evaluating the medications to see if they're causing any change in condition, you're working with the physician of that resident. The pharmacist is working with that physician to say, hey, these are the things, this is a medication you have the resident on. There might be a better medication, this one doesn't have that side effect.
Correct.
Okay, so I want to make sure that we understand that the pharmacist can't change the medication. They have to make the recommendation to the physician.
A very good point. The prescriber, and in this day and age in long-term care, that prescriber may very well be a nurse practitioner or a physician assistant. One of the roles our consultant has is to work closely with prescribers and say, I came in, I reviewed the record today, I see Ms. Jones, who wasn't falling last month, is now falling, and we've given her a drug to reduce her blood pressure. Maybe that's part of the picture. So our consultants will write notes to doctors, they'll write notes to nurses, to the attending physician, to the medical director, and say, maybe we should be using a different drug. How about this? Maybe we should be using a less expensive drug that can do just as well, or a drug with less side effects than this particular one has. So yes, as the consultant is reviewing records, talking with the staff, they are developing these, for lack of a word, care plans from a medication perspective to share with the prescribers and say, is there a way we can do this better with medications, right? So I think you asked a typical day. So our consultants, again, show up at the facility. They're required to review a medical record. And, while documentation is an important part of healthcare, it's not the end of healthcare, right? So yes, we look at medical records. We talk to staff who see the resident every day. We talk to an often forgotten group, and that's the nursing assistant, who is right next to the resident every day doing very intimate things with them, saying how the resident is doing. We talk to charge nurses, and on occasion, and I actually encourage my staff to do this more, is we talk to residents and family about how medication is being received by the resident and how that is going. So how often do we come in is often a question. So in a typical nursing home, the regulation is you have to come in at least once a month. But more frequently, if you have a very sick resident, a resident with lots of medication changes, or think about this, certain in Florida, you have lengths of stays that are less than 30 days. People coming in for rehab, for medically complex issues, who if we waited till once a month to come in to see them, they'd be gone. So facilities that have high turnover, successes of getting people home, our consultants come in more frequently than just once a month to see them. And there's other things that go into this. Length of stay is one, but facilities always have the option when a resident is admitted to the facility, has a change of condition, or they just have questions of calling up our pharmacists who are not physically there and talking about it. With the advent of electronic health records, we can pull up a resident's record from off at a distant location and look at what they're looking at, look at lab results. So there is a formal review and then this kind of informal process and good communication that goes on where we're a real resource to facilities staff to look at. Again, I mean, I'm biased. I work for a pharmacy, but drugs affect residents across the board. And again, what looks like someone who's this whole issue of antibiotic stewardship brings something to light. Today in a nursing home, or at least before antibiotic stewardship started, someone with a change in mental status, I'll ask you, what's the test that was always gotten? If I'm living in a nursing home and I wake up one day and I'm just not acting myself, I can almost guarantee you that someone's going to get a urine culture on me to see whether I have a urinary tract infection. Now, your head and your bladder are pretty far apart, but your body is integrated where things in one part affect another. So there's just drugs, when I give them to you, I can be giving them to you to maybe preserve your mental status from Alzheimer's, but that can have a cardiac effect, a kidney effect, and lots of other things too. So again, you've got the consultants as resources. A typical consultant pharmacist has a doctorate in pharmacy. They have studied these drugs for years. They have years of experience, and most doctors would agree they probably know more than the physician about drugs than the physicians do, and they're a great resource. So you've got them coming in, and then let's see what else. You've got them doing other stuff at the facility. Think about drugs. When you take them at home, your doctor probably tells you to take it on an empty stomach or before meals or after meals. Same kind of stuff our consultants are looking at. We're looking at drug-drug interaction. We're looking at drug-food interaction. We're looking to see whether or not you have an allergy, and we should be not giving you that drug. When I look at the regulations, which are good guidance in this area, we're looking to see whether you're getting a dose that's higher than it should be. So think about it. If you're a 25-year-old healthy young man, you can process drugs well. Our bodies get rid of drugs in two main ways. We urinate them out, or we take them out through bile from our liver. As we age, those are two organ systems that don't work as well as they used to. So if we have a resident who's got significant kidney disease, significant liver disease, how they metabolize a drug can be very different. So our consultants look at kidney function and liver function all the time as they're doing these routine reviews to see whether or not the dose of the drug is appropriate. how long once you're on a drug doesn't mean you need to be on it for the rest of your life. So we look at the duration you're on a drug. I can give you some examples from my days as a surveyor. I'd walk into a nursing home and see someone on multiple eye drops, antibiotic eye drops and steroid eye drops, and they'd been on them for 5 years. When I would research the record, I would learn that 5 years ago they had cataract surgery and post-operatively were put on those drugs, and no one ever took them off them. So you don't need 5 years of antibiotics once you get surgery done, right? Think about it. When you have an allergic reaction at home, you go to your doctor and sometimes they'll put you on steroids to calm that allergic reaction down. Our residents go through it. Sometimes they get allergic to foods or medication, but you don't need to stay on those steroids forever. So we look at duration, we look at monitoring. Consultants look at lab values all the time. They look at vital signs, and monitoring a medication is not just what your lab is. They're looking at the resident and how they're acting. So clinical monitoring is very important. Maybe you shouldn't be on a medicine at all. So I think, again, to get back of antipsychotics, how we got to what I call the war on antipsychotics was for a very specific group of patients, those patients with dementia, with behaviors that were really socially inappropriate, right? Either aggression, either doing things that were socially unacceptable. And what we ended up doing 10 years ago was medicating those people. And I'm here to tell you that medication really doesn't fix problems related to dementia and behaviors. What it does do is sedate people. So that's why we've gotten away from the use of those type meds. Also, because what we learned is when we give you medication to control behaviors with dementia, your risk of death goes way up. So there's a black box, what we call a black box warning on those groups of drugs that say don't use them unless you really need them, because the risk of death from all causes goes up within the first 6 months. What else? So adverse consequences. So many of you have heard of a drug called Coumadin. A lot of our residents use it to prevent strokes and heart attack. Great drug, very dangerous drug. So if you fall while on Coumadin and hit your head, your risk of a bad bleed in your head goes way up. So we look to make sure that we're not using a very risky drug in someone with a lot of falls or other things going on. So that's not a very short version of your answer to your question, but that's plenty of the kinds of things that consultants are looking at.
When you go into a nursing home or an assisted living and you see that they have problems or issues, what's your process to get that fixed?
Great. That's a great question. So it is a question of degree. Our consultant may find a relatively minor problem with medication management. Let's say they believe the patient could use a dose lower than what they're on, but they're stable now. They're not really having any problems. They will reduce that to writing into the medical record. That will get to the physician. He'll evaluate it. He'll either agree with the consultant and lower the dose, or he won't agree with the consultant and write on the recommendation why he disagrees. That's for minor routine stuff. If our consultant walks in a nursing home, and this happens with some regularity, and they pick up a medical record who's on a very high-risk drug and the patient's sick because of it, they won't write anybody. They'll pick up the phone and call the doctor, and they'll immediately intervene if what's going on with the patient is likely related to the drug and having adverse consequences. So that's the spectrum. Communication that may take a week or two to get to the doctor on routine things, immediate phone call to get it resolved on more urgent stuff. Now, think about, you asked about assisted living. So I work with a gentleman who was a pharmacist who, this was his quote that had me thinking a lot. He said, an assisted living is a nursing home in denial. And what he meant by that was many assisted livings are caring for residents that would normally be in a nursing home with much less staff and expertise and resources that a nursing home might have. So, for example, in most states that we are in, a consultant pharmacist goes into an assisted living once a quarter. The likelihood of us stumbling onto a problem once a quarter is less likely than doing it once a month, right? And also, as you know, many of the staff in assisted living may not be nurses giving medications. They may be medicine aides or trained that won't have the expertise. So it is a different landscape in the assisted living environment than it is in a nursing home. And I'm not necessarily, quite frankly, I'm not sure I'm an advocate for nursing homes unless you have to be there. But if you're very sick and you're not well overseen in assisted living, I unfortunately, as you may have seen very bad outcomes that would have been preventable with more resources and expertise. So we value our partnerships with assisted livings. We think it's great, and we try to set up systems that catch things sooner than later. I should also say that every medicine that's ever given to anyone in either a nursing home or assisted living comes through a pharmacist first, right? So just like when you go to your drugstore to get your medicine, a pharmacist is giving it to you. Same with a nursing home or an assisted living. We have a pharmacist in our pharmacies that are looking at drug allergies, that they're looking at the appropriateness of the dose, and they're looking at obvious problems that they can see on the drug regimen. They're not looking at the whole chart, but they're looking at what the order says. So sometimes we stop the problems before we ever send the drug.
What would you do if, and put your CMS hat on for this, if you went into a nursing home and you found that a resident was receiving a medication that was problematic, and you called the physician and you had a conversation with the physician, and the physician was adamant that they were not going to change that medication? Is there, I mean, is that where you stop, or is there another step you can take?
Sure, that's not a hypothetical. I went through that many, many times, right? It is a question of degree about how passionate I would feel. You know, medical judgment is real and fine, and my opinion as a nurse surveyor may have been different as an attending, but let's make this easy. Let's say it's a no-brainer. Let's say it's someone on Coumadin whose job it is to thin your blood and reduce your ability to clot, who's vomiting up blood or urinating blood and is very sick, and the doctor says, I don't want to change. My next step as a surveyor was to pick up the phone and call the medical director. And I would argue that you all in your advocacy role have avenues, right? So you are advocating for residents, much like I did. Nurses are great advocates to get with, charge nurses, DONs, administrators. But you know, the person that ultimately oversees the care in a nursing home is a medical director. That's his responsibility. So I've employed medical directors to intervene in what I consider inappropriate care in many circumstances. You know, as we talked about a little bit before, surveyors carry a stick, you know. Ombudsmen don't have necessarily a stick and much more cooperative. But I believe that most people want to do the right thing for the elderly regardless of what setting they're in. So, you know, you may have a rogue physician or a rogue nurse or someone who just doesn't want to do what seems to be the right thing. And what to me is unacceptable as a human being is to leave that situation and say, I did my part, I can wash my hands of this. I don't think so.
Do you ever, or do you have the ability to make a referral to a survey agency on medications?
Sure. Now that's a great question. So we are working for the nursing home or the assisted living where we both deliver drugs and monitor drugs. We, much like you, are in a position of wanting to help our facilities do the right thing. So a referral to a survey agency would be so far down the line. I believe we could always get to someone in that organization to do the right thing before we had to do that. Is it out there? Just like any citizen can make a referral, I could as well, but I would be hard-pressed to think of a situation where I could not get someone either in a mom-and-pop type organization that would listen or a corporation that would see the value of doing it. So fortunately, as a consultant in a nursing home, we don't run into that or assisted living with any regularity.
One of the things that we run into quite often is we'll have a resident who is on a medication, and the medication is prescribed 4 times a day, and their first dose is at 8 o'clock in the morning, and they want their medication at 8 o'clock in the morning, even though it's 4 times a day.
Uh-huh.
Is the time that the medication is given straightforward, or is that something that the pharmacist can the pharmacist say, you know, instead of change it from 8 to 9, as long as it's 4 hours in between, it's not an issue?
What an excellent question. What a real life, quality of life, excellent question. We do this all the time. As a nurse, I've learned so much working with pharmacists. As a nurse, I too felt like it was really important to give that medicine right on time. And what I've learned by looking at what the pharmacists look at is how flexible we can generally be with medications. Not all, but most medications don't live and die by the clock. The residents may, but the value of the medicine in the body is not nearly as timed to the clock as we think it might be. Here's a great example. Many of your residents, and maybe some of you, take Synthroid, a drug to treat low thyroid. Very common, pretty common in women. A lot of our patients are on it. Here's what the manufacturer says about Synthroid. They say that it is best absorbed on an empty stomach. Let me tell you a case I was actually involved with where a consultant, and this was 20 years ago, a consultant pharmacist came into a nursing home and saw that a resident was taking Synthroid after breakfast every day. Manufacturer says it's better absorbed on an empty stomach. This resident had been taking Synthroid after breakfast for 30 years and was completely stable. The consultant wrote a recommendation to the doctor and said, maybe we should be giving this on an empty stomach. Now remember, the patient is completely fine. The doctor said, sure, do whatever you want. So this particular facility tried to decide when this patient's stomach would be the most empty, and they came up with 4 a.m. So they started waking this resident up every day at 4 a.m. to give this pill on the empty stomach. And when I met this resident, she loved the facility she was in, very complimentary, but she said to me, I am so tired, they wake me up all the time. And when I went back and looked, what I saw was a great example of person-centered care not included in this. Patient was doing fine on the dose of drug when it was given. The consultant pharmacist was technically right, but didn't apply what they know to the situation. And what we did was wake somebody up without regard to their quality of life every day at 4 o'clock. That facility got in big trouble with us for doing that, as a matter of fact. So, long story short, most medicines do not require on-the-clock giving. Some do, and a good example might be Parkinson's related drug. People with Parkinson's disease can be very sensitive to the amount of time away from their schedule that they get those drugs, and they may get very rigid and they may have trouble walking. So I like to say the devil's always in the details.
Okay. So, but if you had your drug scheduled for say every 8 hours.
Yes.
Okay. And the first dose was at 8 o'clock. Mm-hmm. If they change that first dose to 10 o'clock, say that there's no other concerns
going on.
10 o'clock, then 8 hours from 10 o'clock, 8 hours from that point, that could be done.
Absolutely. And we have software that helps our pharmacists take drugs that are typically given 4 times a day and find drugs that will do the same thing twice a day. So we're not interrupting your life 4 times a day to give you medicine. You may be in there with your grandson playing. I don't want to come in and give you a med if I don't have to. So one of the things our consultants do is look for ways to decrease the frequency of staff interacting with residents for institutional-like things like that. Absolutely. And we think that betters people's quality of life.
And these may sometimes be medications that the physician's not aware of?
Correct.
That you could change it from 4 to twice?
Correct. And again, when we say change it, we're going to go to the doctor and say, you've got your patient on drug A 4 times a day. That means, maybe, if they're going out, shopping or something, that might be an issue. Let's try this other drug that we can give it twice a day to get away from, again, bothering them with medication. I mean, medication is not the worst thing in the world to pop a pill in your mouth, but let's try to get away from an institutional approach to people in their older years in healthcare. I think medication is a great example of that. Let's not use it unless we have to, and if we have to use it, let's use it in the most unobtrusive way possible.
And I want to remind the ombudsman watching, please, if you have any questions, please send your questions in. This is probably the first time we've ever had anyone in to talk about pharmacists, so it's important if you have a question that we know what it is so that we can get you an answer. Are there any new medications? We talked a little bit about having a psychotropic for dementia. Are there any new medications that are going to be coming out that can assist the dementia residents?
The blunt answer is probably not, to a dramatic degree. The medicines we have for dementia now and again, I think we all have to be honest about this. We can use medications for people with dementia that can help them maintain the ability to do certain tasks, but whether they gravely improve their quality of life, I'm not sure. And so that is a very tough area. A large majority of people in long-term care have some degree of dementia. We have not found the silver bullet yet, and I wish we could, but medication management is a piece of the puzzle. My vote is, do we do programming better? Do we keep facilities doing activities that keep anxiety down? Or do we have the correct lighting? Or do we have alternative therapies like massage and pet therapy and everything else around a patient with dementia that can support them? The drugs are there, but they're really not the answer. I thought you were about to ask me if, what is the biggest thing in geriatrics right now that is changing when it comes to medication management. And I was ready to answer you with antibiotics.
Well, go ahead and answer that question.
So, all of us have taken antibiotics in their life. Antibiotic stewardship in geriatrics and across the healthcare continuum is really a priority now. So, I'm sure your mom said to you, make sure you finish all your meds, right? Don't leave any of those pills in the bottle. Well, now we're learning that people may be okay without taking a complete course of meds. The way we use antibiotics is changing dramatically. First of all, we're not using them as much as we used to because it was very easy to, if we were in doubt, let's just give Mike an antibiotic. Well, there's no free lunch. Antibiotics can do good things if you need them. They can do really bad things to you if you don't need them. And if anybody has been in a facility where someone has something called C. difficile, a very kind of voluminous and nasty diarrhea, it is a very bad thing to go through, and it's primarily caused by antibiotic use. So we have greatly pulled back in geriatrics on using antibiotics, and instead of using them for 10 days, we've pulled back to 7, sometimes 4. Instead of using a relatively low dose for 10 days, we may give you a very high dose for 3 days and stop there. So and one of the things that we've talked about with our facilities is antibiotic stewardship was coming. It really became regulation last November. Let's not wait till then to talk to residents and family members about this. Let's talk to them about the changing landscape of how we use these drugs, because many sons and daughters believe anytime mom acted a little differently, she must have a urinary tract infection, so let's get an antibiotic in her right away. And that's not the way we work anymore. So antibiotic stewardship is an evolving issue in geriatrics. It is across the continuum, and we're perfecting it. But it is a big change in how we use antibiotics these days. The World Health Organization lists this as one of the top 3 threats to mankind, in that we're running out of effective antibiotics to treat globally illness.
Do you see a big difference by the consultant pharmacists when they're going into facilities that are now using electronic records versus the paper record? Are you seeing more issues with medication or missing medications or poor documentation?
Another excellent question. Here's what I get that question a lot. I would tell you that one day electronic health records are going to be a boom to long-term care, but I'm not certain we're there yet. They come with their own set of issues. Navigating electronic health records, particularly that we have multiple ones out there. There's not just one EHR. We've got a number of vendors that our staff has to get proficient with in X number of electronic health records. There are pluses and minuses. There are, for example, we were talking about documenting medication. An electronic health record, there's a timestamp that documents what time you gave that drug. On a paper chart, there's no exact timestamp. We're saying we gave it at 8, but did we give it at 8:10 or 8:30? The electronic record doesn't lie. So it is a much stricter form of documentation than we have now. It has presented operational challenges for, I think, consultant pharmacists in general, as it has for my nurse colleagues and other ones. It allows us to aggregate data very well. I can tell how many people have developed infections, C. diff. I can pull those drugs out. There's lots of data manipulation we can do that we couldn't do before, but it is not a panacea yet. And Again, I'm hopefully optimistic that one day it will be, but I don't believe we're there yet.
When a consultant pharmacist goes into a nursing home that's 120 beds and they go in once a month, how do they select the charts and things to review? What residents to talk to?
Great question. So let's say it's a nursing home, 120 beds. We have an obligation to look at 120 charts. We will look at every single chart every month. How do we prioritize when we go in there? Certainly nurses grab us and say, could you look at this one first? Or maybe from the last month visit, the consultant pharmacist will have a list of residents they're particularly interested in seeing what the follow-up was like, did the doctor change the drug, and how they are doing. So they may internalize their priority list themselves. The staff may ask them, but at the end of the day, at the end of their visit, they're going to have seen all 120 charts in that nursing home.
What would your advice be to ombudsmen who go into a facility on a case where there is a question about medications? What are the kinds of things that they should look for?
Sure. So my advice would be that if we're talking about a nursing home, the regulations require that our consultants' information be in the very chart you're looking at. So I would encourage you to start reading those things. And our consultants can write very technical notes, that's for sure, but they can write very person-centered care notes as well that talk about basic, common things that we've talked about today. So make it a practice, maybe, just start getting used to reading our consultant notes. You'll see them, and you'll see the responses the physicians have given to our consultants' recommendations. So you'll get used to that kind of flow. Let me talk about a particular reg that's actually new in long-term care this past November that I wanted to make sure I talked to you about. Our residents have always had the right to accept or refuse care, right? You go into a facility, you're a partner with the facility. They're not doing things to you. You're partnering with them. And they've always had the right to accept or refuse medications. There was a new reg that was put into effect. Let's see if I wrote it down. Yeah, for those of you keeping score, it's F552, and it basically says that before I give you a medication in a nursing home, let's say I'm going to start an antibiotic, before I give you that first dose, my obligation is to tell you the risk, the benefit, and alternatives to taking that drug and empower you to choose. And while we think we've done that before, we really haven't. So now nursing homes have to talk to people about, Mrs. Jones, you've got a cough. The doctor did a chest x-ray. We think you have a pneumonia, which is a fairly serious infection. The doctor's chosen, Cipro to give you as an antibiotic. It's usually pretty effective against the pneumonia you have. We think you're going to get better in a couple days. We're going to keep a close eye on you. We're going to give you extra fluids. We're going to check your temperature. And we think you're going to get better. Now, some people that take Cipro, sometimes they get an upset stomach. Sometimes they get anorexia. They don't feel like eating. But a small group of people that take Cipro get probably the worst diarrhea you'd ever have in your life. And so I want you to know that we think you're going to be okay, but there is risk to taking this, right? So that's a kind of conversation that we expect to be having now. And again, I think for ombudsmen, it's very empowering, right? What about the resident with dementia that can't understand that discussion? Well, that conversation needs to take place with the surrogate decision maker. The legally authorized person who can consent to care for that resident is in that resident's shoes, and that's who should be having that discussion with the staff, right? Now, we can go down this rabbit hole for a long way. Let's say the surrogate isn't available, the resident has dementia, can't understand it. Do we just not give the drug until we can find somebody? That has huge risk with it too. So that's often when we involve medical directors and physicians, what is the right thing to do for the resident? And it's a great example of really two competing regulations. One says I have the right to know before you give it to me. Another reg says you should get drugs when you need them. So no black and white in the world of geriatrics.
We're used to when the nurses go in to give the medication, they're supposed to explain what the medication is, what it's for. So what you're saying is now when those medications change, and each time a medication changes, then a new explanation, which is more detailed, has to be given on the first time that new medication is given.
Correct. And the explanation needs to be in terms that the resident can understand, not that you or I can understand. It needs to be without medical jargon. It needs to be in simple language, unless you have a sophisticated resident who wants to do it. So it's an art and a science to explaining this, but there is a very specific reg now. And quite frankly, who can disagree with empowering residents to make decisions or their surrogates? So, yeah, and again, this all gets back to there is risk to everything we do. 10 years ago, if I asked you to name the least risky drug, you would have told me Tylenol. Tylenol is the #1 leading cause of acute liver failure in the U.S. So there is no free lunch. Every drug does good things and has the potential to bad things. And who better to decide that than the person receiving it? And our job as healthcare providers, as a nurse or a doctor, is to empower you to make the right decision, but not make the decision for you.
Okay. Is it appropriate for a resident who suffers from anxiety and has found relief using... I'm reading the question. The question just went wanky. Has found relief using particular medication to be taken off that medication or changed to something that doesn't work?
Another great question. So we're still in a nursing home. Nursing homes have great pressure from the regulations not to use drugs unless they have to. And I think this is the kind of question we get. If it's not broke, why try to fix it, right? Well, I think this gets back to, I'm making this up, I've been on an anti-anxiety drug for 20 years, and I'm on it at a dose of 20 milligrams a day. With that 20 milligrams comes risk. What if I would be just as comfortable on 10 milligrams a day? I am never going to know that unless I do a gradual dose reduction. And so the regs require facilities to attempt that, right? Now, can a resident insist, I don't care, doctor, what you think the right thing to do is, nurse, CMS, I don't care what you think the right thing to do is. It's my body, and I want you to give me 20 milligrams of the anti-anxiety drug today. It's tempting to say yes, the resident should be able to take on all risk and just choose what they want. But let me make this egregious for you. If I'm sitting in a nursing home and I say to my doctor, I want a heart-lung transplant, he's not going to give me a heart-lung transplant unless I need it. So when I say to a doctor, I want this medicine no matter what, he's the prescriber. He has the ultimate authority to say, I believe it's the right thing and I will prescribe it for you. If he doesn't believe it's the right thing, he can't prescribe it. So that's probably a very unsatisfactory answer to whoever just asked that question, but it's the reality of it. Physicians have a duty not to harm people, and a resident has rights, but they're not unbridled rights, right? They're not unbridled. You know, a resident doesn't have the right to smoke in bed. A resident doesn't have the right to use a scooter that knocks people over. There's a line somewhere, and that line exists with drugs as well. I hope that helps.
I think this particular question, the question is that the resident has been taking this medication for a long time. The doctor has changed it. This new dosage or this new medication doesn't work, and they want to go back to what they had before.
Right.
That was working. I think that's where the question
So
lies.
there is a process. So we've gradual dose reduction. You're worse off now than you were. Yes, let's step back and see what else can work. Now, I would argue that maybe you don't need the pill. Maybe you need something else. Maybe you need a different roommate or a different activity program or something else. Let's not focus just on going back to that pill. Let's focus on the big picture and see what we can do to reduce your anxiety in a number of ways. You know, I guess I'm an animal person. I've seen the effects that pets can have on people's anxiety with no side effects except, maybe cleaning up something once in a while, right? So, again, our culture goes to drugs pretty easily, both in the community and geriatrics. Drugs are part of the picture. They're not the only picture.
Do you have any more questions? Okay. How would you approach these common complaints from the family or the resident? The staff are over-medicating my dad, and he sleeps all the time.
There's the opposite end of what we were just asked,
Yes.
right? The opposite end. Well, I would approach it by telling the family and resident not to be silent, right? Bring it up at care plan. Bring it up well before care plan. Say, again, we're making the assumption that the reason dad is sleepy and not as engaged is because of the medicine. And medicines have side effects. We've talked about that today. It may be the medicine, or it may be any number of other things. So I don't want us just to focus on the medicine, but let's look at the big picture of why dad is not engaged, why he's not involved in activities. Is it depression? Is it undertreated thyroid? Is it something else? But I think the takeaway is, you know dad better than the nursing staff might, and dad knows himself better. Let's be an active participant in your care. Let's come to care plan meetings. Let's build relationship with nurses and physicians. Let's not let them leave the room after the examination until I talk to you about my concerns. Let's get active. Sometimes easier said than done, but I think really involving residents and family in these discussions are very important. So you as advocates, as ombudsmen, some people are just naturally uncomfortable talking to a physician, or an older generation may, the doctor's so busy, I'm not going to trouble him with the fact that I have diarrhea 3 times a day. That could be huge, but I don't want to trouble the doctor with something like that. Let's support our residents and family and empower them in a reasonable way to be active in their care, and that can go a long way.
We've seen in the past that the focus was on psychotropics.
Yep.
While that's still in the picture, and then we've seen it kind of move to antibiotics, and that's in the big picture now. But what do you see the next big medication or class of medications?
Yeah, so again, with my nursing home background, CMS just expanded the definition of what a psychotropic drug is. So again, we've looked hard at antipsychotics. Now we're looking at antidepressant, anti-anxiety instead of hypnotics. One of the things that I believe might be out there coming our way is a class of drugs that we call anticholinergic drugs. Those are drugs that cause dry mouth, sometimes makes you hard to pee. They create risk of falls. So that's a class of drugs which there's been literature written about, and many consultants and physicians are already looking at. That may be the next push.
And what are they used to treat?
They're used to treat, Benadryl is a good example. Benadryl is an anticholinergic drug. So we get Benadryl for allergic reaction. We get Benadryl for sleep. If you've ever had a young kid that's going in for a procedure, sometimes you give them Benadryl. So drugs like that can give you dry mouth, difficulty in urination, and other problems. So.
Okay. The question is, I'm in pain, but my staff won't give me my medication. Staff call me a drug addict, or I get my pain med, but I'm still in pain. They don't understand my pain. And I think a lot of that would maybe perhaps come in, one of the diseases would be fibromyalgia, where it's really it's a pain that's real, but it's non-specific. Nobody really knows what it is. And a lot of people say, well, you're not really in pain because you're not acting like you're in pain, but you're in pain.
Well, let's wind that clock back and talk about the opioid crisis and how we have treated pain in the past. And I think it's an evolving issue. I was always taught, and I believe this, pain is what the patient says it is, right? I don't need, I can be in severe pain and not have an elevated pulse and not be crying. And I could be eating breakfast, but in severe pain. Pain management is very much an art and a science. I think you're going to hear a theme from me saying that drugs can help pain, but so can many other things too. There's lots of ways to address pain. And again, maybe this question is getting at, do I have the right to insist on an opioid to treat my pain when the doctor thinks I should get 2 Tylenol? I mean, it's very resident specific, and it's very the devil's in the details. Certainly, we've been through pain as a regulatory priority. Pain's been shown to be undertreated in certain groups. Geriatrics was one of them. I just think the answer doesn't start and end with a pill. I think it starts and ends with a very good assessment about involving the resident and the family and coming to a reasonable decision that might be medication, but might not. Again, no free lunch, and I'll tell you, potent pain meds carry lots of risk with them. From your bowels to falls to, again, sadly, in the communities, the opioid epidemic is a great example of how bad it can be.
Following on, right along on those lines, a lot of times there are scheduled pain medications, but there are also PRN.
Yes.
As a consultant pharmacist, when they go in, will they look at how often a PRN medication is being requested?
Absolutely. So there's a couple things that we'll look with PRN medication. One of the things our consultants will look at is if I'm requesting it 3 or 4 times a day, their recommendation may be, let's not make me get into pain, let's give it proactively, right? That's one approach. In this day and age, many of our consultants, I would say most, will also be looking at non-pharmacological interventions for pain. Am I just giving a pill or am I trying anything else? Is there any other approach to pain management? If a facility is only using medication and not non-pharm, they're not practicing the current standard of care. So they're going to be looking at the big picture as well. But yes, frequency of taking a PRN, I think it's kind of obvious that if I'm truly in pain, and again, let's talk about pain assessment real quick too. The standard of practice generally now when we talk about pain is if Mike's in pain, I'm going to ask him, rate it for me. Don't just tell me I'm in pain. Let's narrow it down, because how I treat a pain on a 1 to 10 scale, how I treat a pain of 2 may be very different than how I treat a pain of 8. So one of the assessments that I'm going to be looking at is, are we going to try to objectively quantify pain in a way that we can manage it better, right? My head hurts could be the worst pain I've ever had in the world, or just a gnawing feeling that I don't feel great either. So objective pain management is important. That, of course, gets tougher when I'm demented and can't necessarily articulate that. So we have pain scales that look at behaviors and try to determine whether those behaviors represent pain. Again, pain management, another complex issue with no real black and white answers.
How effective are drugs like Aricept, and how long should a resident take it when there appears to be no achieved benefits from it?
Well,
and then the resident is given Namnidin, which has the same side effects as Aricept.
Yeah. So I'm not a doctor, nor do I play one on TV. I can give you my own opinion that, again, drugs to treat dementia have a place, but the expectation of families and residents are often not met by those drugs. Unlike curing an infection, let's be blank about this, we're not going to cure the dementia. We may slow its progress, and I think that's the goal. Are we going to be able to slow its progress and make a meaningful impact on someone's quality of life, or are we not? I've seen people on hospice that were 2 days away from dying still on drugs to treat dementia. I'm not sure that's a great use of medication. So there is debate about how long people should be on it. Lots of studies about it. Families that are faced with dementia and the decline are willing sometimes to take anything to help this really difficult situation. And again, drugs have their place, but they are not a panacea when it comes to dementia.
Okay. As a consultant pharmacist, what would you look for when you see a dementia resident with a PRN medication?
Yeah, great question, right? Well, I'd look
if that that resident is not aware. So how is that resident going to ask for that medication?
Yeah, so the obvious answer would be, if a resident with dementia who doesn't have good verbal skills anymore, how is the staff using that PRN drug? I would argue that you don't need to be verbal to receive a PRN medicine. If a resident with dementia had a PRN order for pain, let's say, there are, as we said, scales we can use for nonverbal evidence of pain. It's not nearly as exacting as verbal ones, but there are nonverbal clues to pain. I may have, to be very easy, you may have a PRN order for an antihypertensive drug if your blood pressure goes up. So you can have dementia, I can take your blood pressure, it's high, I give it to you. But I think you're referring to the more kind of nondescript stuff that's not black and white. So people with dementia can still have PRN pain orders. The devil in the detail is, how's the staff using that PRN drug, and on what basis are they using it? How consistently are they using it? Is night shift the only people that are ever giving the drug to someone, or does everyone give it the same, and how are they using it? So again, another good but complex answer to it.
And I think that the real concern there is the staff giving the PRN for the convenience of the staff and perhaps not for the best interests of the resident.
Absolutely. And residents with behaviors, that may be what we're getting at is, I tell facilities a lot, a good quality assurance way to look at medication management with PRNs, be they for pain or behavior, is start tracking it by which shift is more likely to use it. Is the night nurse the only one ever giving the drug at 1 in the morning to maybe keep things quiet? The resident may be acting, the behaviors may be only present at night, but one way to look at PRN management is to look at the frequency and pattern of use to determine whether it's really the resident driving it or is it the staff's interpretation driving it.
We have time for one more question.
Sure.
And this is a thing that we run into quite often, and it's really difficult for the ombudsman to sort out where the truth really lies, is when a resident would complain that I didn't get my medication. Yet when you go look at the MAR or the MOR, you'll see that it's signed off. What would you suggest that the ombudsman do to actually get to what really happened?
Right. So I will use two of my favorite phrases in long-term care. The first I'll say to you, true or false, if it wasn't written, it wasn't done. Is that a true statement? I'll let you think about that for a minute. Of course not. Do you think nurses and doctors write down everything they do? Of course they do. It's unrealistic. And so it feels good to say if it wasn't written, it wasn't done. We can all get on with our lives. It's not true. I'm here to tell you it's also not true that just because something is written in a medical record, it was done. I can tell you the number of times I reviewed records of patients who unfortunately expired on a Monday, and I'm reading the records seeing that they're still getting their lunch and dinner on Wednesday, they're still having bowel movements, they're still being turned to reposition 2 days after their death. So let's look at documentation for what it is. It's a piece of the puzzle. I can tell you how I dealt with it as a surveyor. Mm-hmm. The resident would say to me, I don't get my meds. I would observe a med pass. Now, of course, are people going to act the same when I'm watching? Probably not. But if I got a complaint from X number of residents who said, I didn't get my pain med, that starts getting different. And what it reminds me of is cases of drug diversion. Drug diversion occurs with unfortunate frequency in our healthcare system, and long-term care is not exempt from it. And so I've seen many cases where nurses and other people have been very creative in diverting drugs. So again, an individual saying, last Tuesday I didn't get my drug, the documentation says they did, the patient may have a little bit of memory loss, that's going to be hard to prove. 20 patients who are all in pain, and only when this one nurse is on, life gets a little bit easier to figure out, but that still takes a lot of work.
Right. We have a number of residents who are very aware. They may not know their medications, but they know that they're supposed to get that orange pill.
Correct.
And I didn't get my orange pill today.
Right. And just because I've got a little bit of dementia, and many of the people that I work with say I might have a little bit of dementia, just because I have a little bit of dementia doesn't mean I'm not credible in everything I say. So we have to be careful not to paint people with a broad brush just because of a diagnosis.
Well, Mr. Vaughn, I want to thank you for coming in and speaking with us today. It was very informative. I learned a lot, and we really appreciate you taking this time.
I'd be happy, and to state the obvious, we're a resource. We'll be happy to help you and the ombudsman any way we can. If they ever have questions, please, you've got my contact information.
Okay, and that concludes today's session. Make sure you tune in on February 15th for the guardianship version of Ombudsman Corner. Have a good day.